Imagine going into surgery, right? You're doing it to protect your future chances of having a baby,
Right.
only to find out that the surgery itself just wiped out more than half of your healthy eggs.
Yeah, it's a completely brutal reality.
It is. And that is the long-held gold standard treatment for a very specific, very stubborn type of ovarian cyst.
Yeah.
So if you are listening to this, you're about to get a front row seat to a massive shift happening right now in women's health. Welcome to today's deep dive.
Thanks for having me. It's a topic that is really forcing a reckoning in the medical field right now.
Exactly. We were looking at a highly targeted mini-review by researcher Younis. It is titled Ethanol Sclerotherapy for Endometriomas, a fertility-preserving alternative.
Right. And the mission of this deep dive is to basically look at a showdown between the traditional surgical approach, which is cutting the cyst out, and a minimally invasive chemical alternative.
We're looking at this through one hyper-specific lens, right? We want to know how each method impacts a woman's ovarian reserve, basically the biological bedrock of her future fertility.
Which is such a profound shift to witness. Because, for decades, the surgical approach was just the unquestioned default.
You just cut it out.
Right, you just cut it out. But as we dig into this research, we are starting to measure the true biological cost of that standard.
Okay, let's unpack this. To really grasp the stakes here, we need to understand what an endometrioma actually is. Because according to the research, these cysts affect up to 55% of women who are dealing with endometriosis.
Yeah, that is a massive portion of the patient population.
Right, and these aren't just like simple fluid-filled bubbles. They are cysts on the ovaries filled with old blood and tissue, and they create this highly inflammatory environment.
They do. They cause severe pain. They drive infertility. And historically, they are just incredibly tricky to get rid of.
Now, the standard treatment, surgical cystectomy, it's always made logical sense on paper, right? You have a bad thing, you cut the bad thing out.
Yeah, the mechanical solution.
Exactly. But reading through these sources, the best analogy I could think of is, okay, imagine trying to remove a deeply rooted, stubborn weed from a very delicate, finely balanced garden bed.
Oh, that's a good way to look at it.
Right, like, yes, the surgery gets the weed out. But in the process of yanking it from the dirt, you inevitably lose some of the rich, healthy, essential soil around it.
That analogy actually captures the biological reality perfectly because the soil in this case is the healthy ovarian cortex.
That's the outer layer of the ovary, right?
Yeah, exactly. The outer layer that houses a woman's primordial follicles, which is, her entire lifetime supply of eggs.
Right.
So excision surgery or cystectomy is excellent for one specific thing. It provides what we call histological confirmation.
Meaning the surgeon can actually look at the tissue under a microscope. Like to confirm 100% that it's just a benign endometriosis cyst and not something sinister like cancer.
Precisely. They have the physical tissue in their hands to test, but the data Younis presents on the cost of acquiring that tissue is just staggering.
It really is.
We measure a woman's ovarian reserve primarily through a biomarker in the blood called AMH.
Anti-Müllerian hormone.
Right. And following a surgical cystectomy, the research consistently shows a substantial 40% to 60% reduction in serum AMH levels after just 1 year.
Wait, over half of the reserve.
Yes.
Just gone in 12 months.
Yes.
Just from the treatment itself.
Yeah, just from the surgery. And that drop in AMH indicates a permanent, irreversible loss of healthy ovarian tissue.
Wow.
It effectively accelerates the aging process of the ovary. So you cure the immediate mechanical problem of the bulky cyst, but you severely compromise the long-term biological function of the organ.
Which creates a terrible dilemma for women of reproductive age. They are desperate for relief from the cyst, but they still want to have children in the future.
It is a brutal catch-22.
It really is. The treatment for the thing causing infertility is, in itself, causing a massive hit to their fertility. So because yanking that weed out is so physically damaging to the precious ovarian reserve, researchers had to find a way to neutralize the cyst without actually taking a scalpel to the ovary.
Right, they needed a chemical solution instead of a surgical one.
Which brings us to ethanol sclerotherapy. It is this fascinating, minimally invasive approach that relies heavily on precision ultrasound imaging.
Yeah, the procedure is typically performed transvaginally.
So the physician uses a needle, guided in real time by ultrasound, to puncture the endometrioma.
Exactly. First, they aspirate or drain that thick old blood and fluid that's inside the cyst. Then they flush the empty cavity with normal saline to wash it out thoroughly.
Right.
And finally, they instill the sclerosing agent. In this case, they inject a very high concentration of ethanol. We are talking usually between 95% and 100% pure alcohol directly into the empty cyst cavity.
Wait, ethanol, like alcohol?
Yes, pure alcohol.
You're saying they inject pure laboratory-grade alcohol directly into an ovary. That sounds incredibly toxic. How did that not just poison the entire organ?
I know it sounds alarming, but what's fascinating here is the precise mechanism of action. Think of the cyst like a water balloon deeply embedded inside the ovary.
Okay, I'm picturing it.
Surgery tries to peel the balloon out, which inevitably tears the surrounding tissue. The ethanol method just drains the water out and then uses the alcohol almost like a chemical heat.
A chemical heat.
Yeah, on a cellular level, the pure ethanol rapidly denatures the proteins within the cells lining the cyst wall. It instantly dehydrates those cells and induces what we call coagulative necrosis.
Oh, wow. So to stick with the balloon metaphor, the alcohol acts like a superglue that permanently scars and glues the walls of the balloon together so it can never fill up with fluid again.
That is a highly accurate way to visualize it. You are neutralizing its ability to function, to bleed, and to grow by chemically destroying its biological infrastructure from the inside out.
All while leaving the external structure completely untouched.
Precisely.
I mean, I still have to ask about the safety of using pure alcohol.
Huh.
It is sitting inside a highly vascular organ. Isn't there a risk of that high-proof alcohol leaking out of the cyst, getting into the bloodstream, and giving the patient actual alcohol poisoning during a fertility treatment?
It's a completely natural concern, and it is exactly why the medical community approached this with so much caution initially. But if we connect this to the bigger picture, the clinical data shows a remarkably high safety profile.
Really?
Yeah. There are minor complications in about 10% of cases.
Like what?
Things like transient pelvic pain, a mild fever, or a very small amount of ethanol leakage into the surrounding pelvic cavity. But major complications like actual ethanol intoxication or the formation of an abscess are exceptionally rare.
How rare is exceptionally rare?
The research shows those occur in fewer than 2% of procedures.
Okay, 2% is incredibly low, especially when you compare it to the complication rates for invasive abdominal surgery. But let's talk about the blood alcohol level. Even with a low risk, what happens if some of that alcohol does make it into the bloodstream?
Well, the math here actually provides a lot of reassurance. The total dose of ethanol instilled is strictly controlled based on the size of the cyst.
So they aren't just pumping it full?
No, not at all. It's commonly limited to approximately 1 milliliter per kilogram of the patient's body weight. To put that in perspective, even if that entire dose were somehow absorbed systemically into the bloodstream all at once, it correlates to a blood alcohol concentration of just 0.07%.
Which is actually below the legal driving limit in many places.
Exactly. So while the theoretical risk of systemic toxicity exists, meticulous ultrasound guidance and careful monitoring of the injected volume make this a fundamentally safe, low-risk intervention.
Okay, so we aren't going to accidentally give the patient alcohol poisoning. That is a relief.
Yeah.
But does this actually work better than the scalpel? Because the entire mission of this deep dive is to figure out if filling a cyst with alcohol actually saves the ovarian reserve compared to cutting the cyst out. If we look at the egg reserve data, what is the actual difference?
The comparative data is where the argument for sclerotherapy becomes incredibly compelling. Let's look at the numbers regarding AMH, that primary biomarker we discussed earlier. The review highlights a recent single-center retrospective study that perfectly illustrates the divide. In the surgical group, so the patients who underwent a laparoscopic cystectomy, their AMH levels plunged significantly.
Right, from the 2.48 range down to 1.62.
Exactly. We were talking about losing roughly a third of their measurable reserve in a very short window.
A third of their potential eggs just gone.
Contrast that with the sclerotherapy group in the same study. Their baseline AMH started at a healthy level. After the procedure, their AMH stayed completely flat. It went from 2.12 to 2.09.
So statistically, no change at all.
There was no significant change whatsoever. The biological reserve remained entirely stable, and this isn't just one isolated study either.
There's more.
Yeah. A larger meta-analysis by Lavadia and colleagues confirmed these findings on a much broader scale. They demonstrated a drastically greater decline in AMH after cystectomy, with a mean difference of 1.69 nanograms per milliliter compared to sclerotherapy.
Wow.
The evidence is remarkably consistent across multiple studies. If preserving the ovarian reserve is the primary goal, avoiding the scalpel is paramount.
Here's where it gets really interesting, though. Because in reading through these sources, I noticed something that seemed almost counterintuitive.
What's that?
Well, some of these reviews didn't just show that sclerotherapy kept the reserve stable. Some studies actually reported an increase in something called AFC after the procedure.
Ah, yes.
And AFC is the antral follicle count, right?
Yeah.
It's the ultrasound tally of the visible resting eggs in the ovary.
That's right.
So how is it possible that a chemical treatment could make the ovary seemingly produce more visible eggs?
It's a fascinating phenomenon. To go back to your earlier analogy, imagine a massive boulder sitting on top of a garden hose. The water just can't flow through. And endometrioma acts like that boulder. The physical mechanical pressure of a large cyst stretching the ovarian cortex actively suppresses the normal development and visibility of the adjacent healthy follicles.
They are physically compressed.
Yes.
So it's like decompressing the real estate. Once you drain the fluid and shrink the cyst with the alcohol, you relieve that mechanical pressure, and the healthy tissue that was being crushed suddenly has room to breathe and function normally again.
Decompressing the real estate is an excellent descriptor. The ovary physically rebounds. However, I do need to offer a note of clinical nuance here.
Okay, what's a catch?
While seeing an increase in the antral follicle count is an encouraging sign of recovery, AFC is a subjective measurement. It is subject to variation depending on the specific ultrasound equipment and the technician performing the scan.
So it's not a perfect metric.
Right. The researcher Younis cautions that AMH, the blood test, remains the much more sensitive, reliable, and objective biomarker for true ovarian reserve. So we shouldn't claim that sclerotherapy somehow creates new eggs.
Right, it doesn't manufacture eggs out of thin air, but it stops them from being hidden by pressure, or worse, destroyed by a scalpel.
Precisely. The overarching conclusion remains rock solid. It preserves the existing reserve far, far more effectively than excision.
Okay, but if this is so perfect, if it saves the egg supply, avoids general anesthesia in many cases, and keeps the patient out of the operating room, why isn't every single doctor doing this right now?
That is the big question.
Right. If a patient walks into a clinic tomorrow with a painful endometrioma, why might a surgeon still push for cutting it out?
It comes down to a single frustrating word: recurrence.
The weed grows back.
It does. This remains the primary limitation of conservative, non-surgical approaches. Let's compare the rates.
Okay.
After a surgical cystectomy where you physically peel the entire cyst wall out of the body, the recurrence rate of the endometrioma is roughly 20% to 50% over a 5-year period.
That's still pretty high for major surgery.
It is. But after ethanol sclerotherapy, the documented recurrence rates vary wildly in the literature. Anywhere from a highly successful 10% all the way up to a dismal 60%.
60%? That's terrible. If the cyst just comes back more than half the time, aren't we just kicking the can down the road?
That's the argument.
Yeah, I mean, why put a patient through multiple needle procedures if the alcohol doesn't even kill the cyst permanently?
That is exactly the argument many surgeons make when advocating for excision. However, this is where a deep dive into the specific research data is so illuminating. Why is there such a massive variance from 10% to 60% in the sclerotherapy outcomes?
I don't know why.
It all comes down to procedural technique. A systematic review by Kim and colleagues found a critical nuance. The duration of ethanol exposure is everything.
How long it sits in the cyst.
Yes. When doctors injected the ethanol and let it sit in the cyst for more than 10 minutes, the recurrence rate plummeted to an average of just 13.8%.
Wow. So the doctors who are seeing a 60% failure rate were simply rushing the procedure. They were washing the alcohol out before it had time to actually do its job.
Exactly. Because it is often an outpatient procedure, sometimes done with only local anesthesia, there can be a clinical push to complete it quickly for patient comfort.
Which makes sense. No one wants to be uncomfortable.
Right, but the biology of coagulative necrosis requires time. The chemical heat of the ethanol needs those 10+ minutes to fully penetrate and ablate the thick, fibrotic tissue of the cyst wall.
So when they actually wait the full 10 minutes.
When the protocol is standardized correctly, the 13.8% recurrence rate of sclerotherapy is actually highly competitive with, or even better than, the surgical recurrence rate.
That completely changes the narrative. It's not a failure of the method, it's a failure of the application.
Furthermore, and this is a vital point to understand when comparing the two treatments, even if recurrence does happen, repeat sclerotherapy is feasible and does not entail cumulative surgical trauma.
Okay, let's break down cumulative surgical trauma for the listener. Because that sounds intense. What does that actually mean for the patient's body?
Every single time a surgeon opens the abdomen and cuts into the ovary, they create structural damage. They create scar tissue. They create pelvic adhesions, which is where internal organs literally stick together.
Oh, God.
And inevitably, they remove more healthy ovarian cortex. If a woman needs 2 or 3 cystectomies over a decade because her endometriosis keeps returning, her ovarian reserve will be utterly devastated by the sheer accumulation of surgical trauma.
Right.
But with sclerotherapy, you are just inserting a needle under ultrasound guidance. You aren't creating external pelvic adhesions. You aren't stripping away more soil.
So you can safely repeat the procedure if the cyst returns without compounding the structural damage to the reproductive organs.
Exactly.
You can basically spray the weed killer a second time without having to rip up the entire garden bed again. That makes total sense.
Yeah, it really does.
Okay, so preserving the AMH levels on a blood test is fantastic. Avoiding major surgical scars and adhesions is fantastic. But let's bring this back to the absolute most important concern for the listener who is navigating this diagnosis.
The real-world results.
Right. Does preserving this biological reserve actually result in successful pregnancies? Because at the end of the day, we are moving from talking about biomarkers in a lab to actual reproductive outcomes. The ultimate goal here is making babies.
And the data on reproductive outcomes is where this truly shines. Following ethanol sclerotherapy, reported overall pregnancy rates range from 30% to 40%.
Which is highly promising.
It is, but the most crucial data emerges when we look at patients who specifically undergo in vitro fertilization, or IVF, after their treatment.
Okay, tell me about the IVF data.
In the context of IVF, preserving that ovarian reserve pays massive dividends. A key study by Cohen and colleagues observed the outcomes of IVF cycles and found a significantly higher average oocyte yield, meaning the total number of eggs retrieved during the IVF process, in patients who had sclerotherapy compared to those who had a cystectomy.
Right, because the sclerotherapy patients had more of their reserve intact, so they were able to respond better to the IVF stimulation medications.
Exactly. The surgery group had a diminished reserve due to the excision, so their ovaries simply couldn't produce as many eggs when stimulated by the fertility drugs.
They just didn't have the supply left.
Right. The sclerotherapy group, having avoided that surgical trauma, maintained their ovarian responsiveness.
So what does this all mean for the listener? It means that for a woman who is looking to freeze her eggs or who is about to undergo the grueling process of IVF, avoiding the scalpel and opting for this ethanol treatment means she brings more eggs to the table.
Yes, she does.
And in the world of IVF, the number of eggs you retrieve is arguably the single biggest predictor of eventual success, right? Every extra egg is an extra chance at an embryo.
That is absolutely correct. And to solidify that point, the recent meta-analysis by Lavadia didn't just look at the number of eggs retrieved, it looked at actual resulting pregnancies.
Oh, really? What did they find?
Their findings showed significantly higher clinical pregnancy rates following ethanol treatment compared to surgery. It proves that the eggs being saved by avoiding surgery aren't just present in the ovary, they are viable.
That's incredible.
Yeah, sclerotherapy preserves the quantity without impairing the implantation potential or the fundamental quality of the embryos.
So as we wrap up this deep dive, the key takeaway for you, the listener, is profoundly clear. When dealing with endometriomas, the old gold standard of surgical excision might simply be too aggressive, too damaging for those who want to prioritize and protect their future fertility.
It's a trade-off that patients really need to be aware of.
Yes, ethanol sclerotherapy requires a very precise technique. We have to remember that 10-minute rule to prevent the cysts from coming back. But it offers a highly effective, minimally invasive alternative. It protects that precious ovarian reserve. It often avoids the need for general anesthesia and hospitalization. And ultimately, it leaves the door to parenthood much wider open.
It is undeniably a vital tool for individualized, fertility-oriented care. However, as is the nature of scientific inquiry, answering one question invariably opens another.
Well, of course it does.
I want to leave you with a final unresolved puzzle from the frontiers of this research to ponder.
Lay it on me.
Through this discussion, we have contrasted the visible physical damage of surgery against the apparent safety of sclerotherapy. We know excision physically removes healthy tissue, but there is a theoretical, currently invisible risk with sclerotherapy known as diffusion.
Diffusion? You mean like the alcohol potentially seeping through the walls of the cyst?
Exactly. Experimental animal models using rats have shown that when ethanol is injected into simple ovarian cysts, the alcohol can sometimes diffuse through the cyst wall into the adjacent healthy ovarian cortex.
Uh-oh.
In these animal models, this microscopic exposure to alcohol caused stromal fibrosis, essentially scarring, and the loss of those precious primordial follicles sitting just outside the cyst.
Wait, so the alcohol might be silently killing the eggs right next door without us even seeing it?
That is the theoretical concern. The catch, however, is that we currently have absolutely no human model to measure this accurately.
None.
No, we do not know how deep or even if that ethanol penetration occurs in human endometriomas, which have much thicker, highly fibrotic walls compared to the thin cysts in the rat studies.
Okay, so the rat cysts are thin, human ones are thick. That might protect them.
It might, and the human data clearly shows AMH remains stable, which strongly suggests the damage, if it exists at all, is minimal compared to the guaranteed destruction of surgery.
Right, surgery definitely destroys them.
Yes, but it raises a profound question. As medical science advances to save our biology from the brutal trauma of the scalpel, are we, in some cases, simply trading visible surgical damage for microscopic chemical changes that our current technology cannot fully measure yet?
Wow. Are we inadvertently poisoning the soil right next to the weed without even realizing it? That is a fascinating, slightly unsettling thought to chew on.
It is, isn't it?
It just goes to show that in medicine, every single intervention is a calculation of risks, and the pursuit of the perfect, consequence-free treatment is an ongoing journey. Thank you so much for joining us on this deep dive, and we'll catch you next time.